Good evening, everyone. I'm Neil Love from Research to Practice, and welcome to this keynote presentation of our 5th Annual General Medical Oncology Summit. We're going to be here all weekend until Sunday with many different investigators today. Tonight, we'll be focused on the management of follicular and diffuse large B-cell lymphoma. We have almost 40 investigators coming here to Orlando. We're really happy to be able to work with them. As in all of our programs, we will be discussing the use of unapproved agents and regimens, so check out the package inserts for more information. Today we're here to talk about diffuse large B-cell lymphoma and follicular lymphoma. We have a great faculty today, Dr. Manali Kamdar from the University of Colorado Cancer Center in Aurora, Colorado, and then Dr. Krish Patel from the Sarah Cannon Research Institute in Nashville, Tennessee, and Dr. Gilles Salles from the Memorial Sloan Kettering Cancer Center in New York City. Here's our agenda for tonight. We have a lot to talk about here. We're going to start out talking about diffuse large B-cell, and then we'll move over about halfway during it to get into follicular lymphoma. So before we start, our theme in general for all of our work is we're always trying to ask you all good questions. And every year at this conference, we like to look back over the past year and try to identify times that we've asked good questions. So here's our hematologic oncology version of That's a Good Question.
That's a great question.
So that's a very good question.
That's an important question.
Another important question.
So that would be another interesting question.
That's absolutely a very important question.
Yeah, all great questions.
I think that's an excellent question.
Great questions.
A good question.
Great question.
That's a really important question.
It's a good question.
Yeah, that's a great question.
I think a very important question.
A great question.
A great question.
It's a great question. This is a fantastic question.
That's a super question, Neil.
It's a great question.
Very important question.
This is a great question.
This is a great question.
It's a great question.
Great questions, Neil.
So, what we like to do in general, what we're doing this weekend is really just sit down. Research to Practice is really patterned on rounds. When I was in training, I always loved making rounds, and there's always certain people who just have that ability to communicate, and really that's what it's about. It's such a pleasure and honor to have people come here to Orlando and meet with us here today. So one other thing I want to just mention before we start jumping into the content is, like everybody else, I'm getting to be a big AI fanatic. And Gilles, last week we were doing some webinars, and we were doing a program on colorectal cancer, and I decided to ask ChatGPT, well, what do you think was the most important paper of the year? And it turned out that I could see what ChatGPT was looking through, and it came up with a paper. It wasn't even on my list of the best papers, which was actually adjuvant exercise in colorectal cancer, which seems to have improved survival and PFS survival. But I thought we could just take a deep breath and just start out, and we're going to do this for most of these sessions, and ask the faculty what they think was the most important paper, the most important new concept, what's really going to be affecting us over the next few years. What do we have to look forward to in ASCO in both diffuse large B-cell as well as follicular? I can tell you, Gilles, when I asked ChatGPT about follicular, it said EBCOR FL1, which of course we're going to talk about here, epcoritamab, the bispecific with R-squared, and diffuse large B-cell. It brought up the updated data from Polarix and Zuma-7. But I'm just kind of curious what your thoughts are from your point of view of some of the more exciting data we've seen in the past year in these two non-Hodgkin lymphoma, Gilles, and where do you think we're moving in general?
Well, thank you, Neil, and thank you for having us tonight. To me, the most important paper that was published recently was a paper by Mazia Shanwan in the name of the SWOG group in follicular lymphoma. This is the update with 15 years of follow-up of the clinical trial that associated combined rituximab in CHOP in newly diagnosed follicular lymphoma. We all write papers days and days, starting like follicular lymphoma is an incurable disease. Since a couple of years, I started to tell my fellow, don't write that anymore. Well, this paper shows that there is a 30 to 40% chance of being cured with follicular lymphoma treated with R-CHOP. There is a nice statistical discussion, a nice simulation of what will happen if there are more relapses, but it's clear from this study that there are patients that after 15 years of follow-up, haven't evidence of disease. I think it's a change of paradigm, and it's a very important paper.
Yeah, maybe it ties into, too, the topic we're going to talk about is CAR-T, where at least initially I kind of thought, well, this is not really working the way it does in diffuse large B-cell, but we'll talk more about that. So, Krish, anything you want to add to that? Any favorite papers or presentations? I see that there's a late breaker coming up at ASCO, Frontmind, Phase 3 of TAFA plus lenalidomide and R-CHOP for diffuse large B-cell. That should be interesting. Any comments?
Yeah, absolutely, Neil. I think that may be one of the most important trials in DLBCL that we see. We've seen a press release. We haven't seen the data, but the study was positive, and I think there'll be a lot of interesting analysis of that trial, especially as we think about subsets of DLBCL, and is this a regimen that benefits all comers? And so very excited about that.
Manali, again, any favorite papers or presentations over the past year, and any predictions about where we might be with follicular and diffuse large B-cell in the next 3-4 years?
So I concur with my other two speakers. But in addition to that, I think I'm very pumped about the combination of mosunetuzumab and polatuzumab. Extremely community-friendly, could be done in an outpatient setting. The SUNMO study shows its value in diffuse large B-cell lymphoma. And then most recently, we published a paper in mantle cell lymphoma where the durability actually looks quite good. With regards to some new assets that I'm really looking forward to, I would say the BCL6 degraders are looking mind-blowing in diffuse large B-cell lymphoma. Some early data was presented at last year's ASH, so looking forward to the follow-up.
BCL6 degraders?
Yep.
Interesting. We're seeing degraders all over oncology, obviously BTK degraders, breast cancer, ER degraders, prostate cancer, androgen degraders, so maybe that'll be in our future as well. All right, so we're going to go back and forth, and I'm actually going to interrupt the faculty during their talk so to bring out some conversation. If you have any questions, feel free to throw them in here. But Gilles, let's start out with the diffuse large B-cell antibody-drug conjugates, and particularly follow up on the Polaric study and other ADCs.
Yes, thank you, Neil, again. So this is my disclosure. I consult or participate to advisory committee for several companies developing drug in this area. So let's start with Polarics, and just remember that this is an antibody-drug conjugate. It targets CD79, which is broadly and widely expressed in all mature B-cell malignancies. It delivers MMAE like brentuximab vedotin, etc. in Hodgkin lymphoma. And we had run many years ago a phase 2 study combining polatuzumab vedotin with R-CHOP in first line. So the design of the study, which is important to remember, it's a double-blind study, meaning that the patient either receive R-CHOP or polar R-CHP, meaning that neither the patient nor the physician did knew whether it was vincristine or polatuzumab vedotin. It was a randomized trial with 800 patients. You have seen the presentation in the New England a couple of years ago, and I had the privilege to show this data at ASH 1.5 years ago. They were recently published in GCO. This is a 5 years follow-up of the study. You remember that there have been many studies in the field of DLBCL not showing any improvement of PFS in the intent to treat population. Here you have a 6.5% difference at 2 years, which is maintained around the 6% at 5 years. And you see that the difference that is seen early is maintained through the time with a hazard ratio of 0.77 at 5 years. So what does that mean for patients? That means that if the patient receives polar R-CHP, they get fewer second-line therapy, including polatuzumab and bendamustine, including CAR T-cell, including transplant, bispecific, any other kind of chemo, so less burden in terms of their care because they have a higher chance probably to be cured with first-line treatment. And unfortunately, or that's the observation with this data, there were no overall survival benefit probably linked to the efficacy of second-line treatment. Maybe this data will continue to mature. You can see that at 2 years, there were only 4 deaths of difference, 4 patients that die in addition in the R-CHOP arm. It's 12 at 5 years. Maybe we will hear in the future some updated analysis. What has been raising a lot of comment is eventually whether some subgroup benefited more, and I'm sure we'll have questions. But I think that's also a very important slide in this field, which is the equivalence in terms of toxicity of R-CHOP and polar R-CHP. The two major differences are, the major difference is the rate of febrile neutropenia, 9% with R-CHOP. The median age was over 60 and almost 14% in polar R-CHP. You have to give GCSF prophylaxis to this patient. Maybe a little bit more diarrhea with polar R-CHP, a little bit less constipation, and no difference in the rate of neuropathy. And again, the fact that it was a double-blind study raised that. So that's on this basis that the drug was approved for patients having an IPI 225 newly diagnosed DLBCL.
So maybe before you go on, we stop the timer incidentally when we ask questions, so we make sure you have enough time to do your presentation. But Krish, one of the big questions that come out from the beginning, and Gilles was kind of alluding to it, is whether you can pick out people maybe who wouldn't get this, and particularly, obviously, cell of origin. So where do we stand with that? And any comments in terms of quality control of cell of origin in the community? Are we getting accurate information?
Yeah, that is a great question, Neil. So in this study, cell of origin was defined by gene expression profiling. And so that is not a tool that we have readily available in the community. We commonly use IHC. There can be some discordance in IHC and GEP. That said, what the study did show is the greatest benefit was in those patients who are non-GCB by gene expression profiling, whereas the GCB patients appeared to have comparable outcomes with R-CHOP as with polar R-CHP.
So do you actually utilize it clinically, cell of origin, in your decision-making, Krish?
I personally do not, and that's partly because most cell of origin we get is done by IHC, and so I will generally use the IPI designation per the label to select it, but that does vary around the country.
So our way of doing consensus is we ask a bunch of people, they all say the same thing, we call it a consensus. So do you use cell of origin, Manali?
I don't.
Gilles?
I don't.
All right. Let's move on then.
So the second advances that we may see in the field, sorry about that, is what's happening with BTK inhibitors. Remember that we had a lot of hope with these drugs based on the work done at the NCI, showing that there were a selective subgroup of DLBCL, the so-called activated B cell, ABC DLBCL, who may be sensitive. And the first trial, which was a Phoenix study, which was R-CHOP plus or minus ibrutinib, was a negative study despite the fact that younger patients appeared to benefit from the addition of ibrutinib. And when subsequent genetic analyses were done by the group of the NCI, that shows that two molecular subtypes that we don't identify in routine practice, the so-called MCD and N1, had a 100% overall survival and PFS outcome. So the study has been continued. Maybe there were toxicity from ibrutinib, maybe other BTK inhibitor may be well tolerated. The study also performed from the NCI showed that acalabrutinib can be used safely in combination with R-CHOP, and there were a couple of other studies showing that. So we are expecting the result maybe in 2026, maybe later, I don't know, of a study called ESCALADE. And this study recruited patients which were, as you can see, younger, up to 65 years, and they had DLBCL, mostly non-GCB, determined by FFPs. There will be molecular analysis performed. And after one cycle of R-CHOP, they were allocated to receive either continuing R-CHOP with placebo or Acala R-CHOP. I don't know the result of this study, but it could be a practice-changing study if this patient determined by IHC benefit of adding acalabrutinib. So keep posted, keep your eyes open. We may hear about that hopefully before the end of the year.
Quick question back to you, Gilles. Any situations right now where you'd use a BTK inhibitor? Maybe a patient might even bring it up to you. Nowadays, people look at ChatGPT themselves and might see this study. They say, what about giving me acalabrutinib? Any thoughts?
Well, I think it relates to the Polaric study. The Polaric study already showed a marked benefit in the non-ABC defined, 25% difference in PFS, 15% of difference in OS. Subgroup analysis to be taken with a grain of salt. So at this time, I don't see the reason to add an oral agent that may have some side effect, may complicate. But maybe things will change. The next study I would like to discuss, we'll come back to polatuzumab vedotin, is this study that was testing R-GemOx versus adding polatuzumab vedotin to R-GemOx. We have been used to use polatuzumab vedotin with BR. This is with R-GemOx. It's a randomized study in transplant-ineligible relapsed refractory DLBCL. And the result of this study, which recruited quite older patients non-eligible, are depicted here. There was a significant benefit in terms of overall survival. There was a significant benefit in terms of PFS. This is important data. Obviously, it's a death of R-GemOx, I will say. All the studies that were published this year show that R-GemOx is not a good regimen. Using polatuzumab to add is very easy and rather well tolerated. We'll see that. And it's improved overall survival and PFS. One aspect that was surprising to some people is that this benefit of polatuzumab vedotin was seen in both ABC and GCB cell of origin. And regarding toxicity, obviously a little bit more toxicities. Patient receives the drug for a longer period of time, more neutropenia, thrombocytopenia, a little bit more neuropathy, 3% or so of patients having grade 3 neuropathy. So you have to be careful. You have to monitor your patient. Oxaliplatin and polatuzumab vedotin are two drugs that are toxic for the nerve. So if your patient had diabetes or other pre-existing condition, maybe diminish the dose or pay attention to that. Otherwise, it's a very easy to manipulate regimen. I will say in the relapse setting, we have bispecific, we have CAR-T, but if we don't have access and can't use those, it's a very reasonable regimen. So, continuing on the field of antibody-drug conjugate, you are now familiar with loncastuximab tesirine, that we call also lonca-T. The approval, preliminary approval of this drug, accelerated approval, was based upon this study, which was a study performed in patients with relapsed refractory DLBCL, mostly in third line. You remember how you manipulate these drugs. The two first cycles have a higher dose, then you drop to a lower dose, and you repeat one infusion every 3 weeks. These were heavily pretreated patients that received this drug, and the results have been presented, published, and have been updated this year. As you can see, about half of the patient response, overall response rate, 48.3%. Half of them have a complete response. And what happens to this patient with a complete response? You can see that they obtain a complete response in the range of 6 weeks, so you can quickly decide whether the patient benefits or not with this drug. And with I reach a CR, they receive up to 8 of 12 administration of this drug. We'll discuss that. But this is the duration of response. In orange is all patient responders. The darker one on the top is patient with a complete response. I mean, these are quite impressive curves. If you reach a CR, you benefit for this CR in the relapse refractory setting. So it may be worth using this drug in the relapse setting, although combination can be envisioned. Again, in terms of tolerability, it's not necessarily the easiest drug to manipulate. There are some edema, there are some reactions. We are in Florida, so if your patients are exposed to sun, I think they have to wear sun protection during the administration. There is photosensitization. And you can see there are also a few patients with peripheral edema. You have to use a little bit of diuretics and things like that. It's manageable, but you need to pay attention, and probably after the 6 cycles, it starts to be difficult to deliver in many patients. Based on these studies, there is a randomized study, which we probably expect to be seen in 2026, another one, which is the one that will lead to a confirmed approval of this drug, which is loncastuximab plus rituximab versus loncastuximab versus R-GemOx. So again, R-GemOx probably will be beaten, but I don't know. And, the accrual has been done. We will see the result probably in the near future. And finally, we were all excited to see since 1 year the combination of lonca-T plus a bispecific, glofitamab. I will not disclose what Krish Patel will say, but these bispecific are taking a huge place in the management of patients. Here, the patient started with the obinutuzumab pretreatment, then started loncastuximab, and then were combined loncastuximab and glofitamab. So it was, again, a very difficult to treat population. Look, median age of 70, many patients had had several lines of treatment. maybe not that many, but most of them were really refractory to the last line of therapy, only a few failing prior transplant or CAR-T. And in terms of tolerability, we do know that glofitamab and bispecific need a specific management, but basically, if you look at the lower dose, there was, yes, a significant number of patients, 55%, experiencing CRS 1, 2, or even 3. If you look at the higher dose, 150 milligram, as priming before the bispecific, you have only 1/4 of the patient having CRS grade 1, which is usually managed with hydration and steroids, probably in your practice, so rather easy to manage. There were very few ICANS, 1 grade 2 ICANS treated with steroids. So something that is manageable, but what was impressive was that the overall response rate in the 90% range, the CR rate, as you can see, in the 85+ range. So the vast majority of patients get a CR. Again, this can be observed in 6 weeks. These are preliminary data. We'd like to see consolidated. Maybe randomized trial will go in this field. But I think if your patient can tolerate bispecific, probably combining them with something like Lonca-T is a good option, but we'll discuss other options in the very near future.
So, Manali, I feel like we talk about ADCs every day in oncology, all parts of oncology exploding with ADCs, particularly breast cancer and many others, hematologic cancers as well. And it's always kind of difficult in the beginning to get a real feel for what it's like to use these drugs. Is it like chemo? Are you getting any effects? Is it a payload or is it the target? Your colleague, Matt Lunning, likes to say we shouldn't call this Lonca-T, we should call it Lonca-T/Dex, because he thinks everybody should have corticosteroids. What's your experience? How do you utilize corticosteroids with Lonca-T? How tolerable does it really turn out to be?
Yeah, I think the success of Lonca-T depends on the pre-medication. Pre-medication with DEX is built into the PI insert, so it's very essential that we do that. It's also very essential, besides what photosensitivity we talked about, and to really be able to tell our patients how to tackle it. A lot of photosensitivity rashes can also be dealt with topical steroids, really respond very well. And then pulmonary peripheral edema, pleural effusion, all of these things have to be watched for, especially in the first 2 cycles. Catch them quickly, hold the infusion if needed, treat them with diuretics. But I think pre-medication with DEX is key to the success of Lonca-T.
And Krish, if it turns out that in the phase 3 setting, the combination of glofitamab and Lonca-T looks very promising. How do you anticipate that's going to be in terms of tolerability? And I know it'll depend upon the magnitude of the benefit, but how are you going to integrate a combination like that?
Yeah, one of the interesting things about the data we've seen so far is how much a single dose of the ADC might actually decrease the toxicity of the bispecific. That may be a debulking effect. So I think it may be really intriguing to see if that actually improves the ability to deliver a bispecific in the community, as Dr. Salles pointed out.
All right, so cell mods. I didn't know that we'd be talking about that here, but here we are.
Yeah, well, here we are. The drug is not yet available, but it's a drug that is in development, and I think it's quite exciting. We have tried lenalidomide, a few other drugs failed. Golcadomide is the next drug in class, and just means this slide is very complicated, sorry about that, but there are 2 transcription factors, Aiolos and Icaros, which are really important for the biology of B cell and for the survival of B cell, NF-kappa B, you may have some remembering about that. So what this drug does is that it brings these 2 molecules to degradation in the cell. So that's the reason they are called cell mods. So it's a drug that has been used as a single agent in combination with rituximab, but what was quite impressive, what presented 1 year ago in the ICML, was a combination of golcacomide with R-CHOP. It took a while to really find the right dose to be adopted, but I think we have now the dose, we have now the way of administering it, and as you can see, the vast majority of the patients achieve a CR. For most patients, the CR was durable. You can see the PFS rate in the 85%, 91% of the patients were alive at 1 year, and there are some MRD data that suggest a major effect. So this led to another randomized trial in the field, which is placebo R-CHOP versus golcadomide R-CHOP. This trial has been fully accrued. I don't think we'll see the result in 2026 for sure, not in 2027. Maybe we'll have to wait another year. But this will be another element, and we'll be facing many possible combinations with R-CHOP, which probably we will have to adapt in terms of tolerability, in terms of subgroup of patients, and decide what is best for each patient.
So just a final follow-up here to this last topic, Gilles. I'm curious, how effective is lenalidomide in diffuse large B-cell? And what about tomorrow we're talking about myeloma. There's 2 cell mods there, and one, actually, iberdomide, is going to be incorporated in the new phase 3 determination trial, which is really amazing. Dr. Richardson's excited about these, less second cancers, better tolerated. How come the myeloma cell mods aren't being, or have they been looked at?
No, they have been looked at. I mean, iberdomide and others have been looked at in lymphoma, but the most potent after lenalidomide, which gave, 20-30% response, a few complete response. If you're able to combine it with a BTK inhibitor in non-GCB, you have maybe half of the patient in response. If you want to try to use a famous Viper regimen from our friend from NCI, you can do this combination. But having said that, golcadomide seems to be much more powerful. It's independent of the cell of origin. You have just to find the right way to administer it. And I think this one is more selective for Icaros and Aiolos and have more effect in DLBCL and follicular than iberdomide or the other ones that were developed in myeloma.
All right, let's move on now, talk about monoclonal and bispecific antibodies. And as we go along here talking about diffuse large B-cell, we're kind of building up sort of a profile where things are research-wise, and then hopefully we can kind of pull out from the faculty what it means to taking care of patients. Krish?
Great. Thank you, Neil. So we're going to talk about a lot of different antibody-based therapies in DLBCL. These are my disclosures. Not so long ago, DLBCL management was a lot simpler. 10 years ago, largely chemotherapy in the first line, chemotherapy in the second line, maybe chemotherapy in the third line. We had very limited tools, and just 10 years later now, if we think about the landscape of DLBCL, you see all of these green boxes are approvals, advances. This comes from the NCCN guidelines. Not all of these drugs are approved, but many of them have high-level data. So we're going to focus on the antibodies that are new and the bispecifics, and in particular in combinations in DLBCL. Just to point out that there are really 2 in the U.S. that are largely used for DLBCL today, epcoritamab and glofitamab. These have global approvals across the world, as you see the number here. There are other bispecifics as well, but also combinations with mosunetuzumab, and we'll talk about these. I think you all know this well, but bispecific antibodies in lymphoma are T-cell engaging therapies. So we engage a tumor antigen, in this case CD20, with the approved therapies, and CD3 on the T-cell for the purposes of T-cell activation to direct T-cell mediated killing of the lymphoma. This is HLA independent, so it doesn't require antigen presentation. And we have very different ways we can construct a bispecific. But basically for the 2 that are available today, glofitamab has a 2-to-1 antigen binding ratio, so 2 CD20 binding sites. Epcoritamab is 1-to-1, but essentially these work in a similar way. We do see CRS with bispecific antibodies, but we can mitigate this with step-up dosing, and these are generally low grade. So the first combination study I'll talk about is in the second-line transplant-ineligible population, and this is for glofitamab in combination with GemOx versus rituximab GemOx. And so what you see here is a doubling of overall survival. This is a phase 3 study, the STARGLOW clinical trial, with a median follow-up now of just about 3 years. You can see the hazard ratio here, and a separation of these survival curves that is sustained over time, and perhaps we're starting to see the beginnings of a plateau in the late portion of the survival curves as well. In terms of CRS, what we saw is largely consistent with glofitamab monotherapy, 45% CRS rate, but most of this is grade 1, as Dr. Salles pointed out. That is a fever alone, often manageable in the outpatient setting, and this is a therapy that can be given in the outpatient setting with monitoring of the patient and counseling. There are very few high-grade events. One of the things we recognize across bispecific antibody trials is that there is deeper B-cell depletion, and we do see a risk of infection associated with these therapies, so that's something important, also shown in the STARGLOW trial. If we look at a different combination of a bispecific, now not with traditional chemotherapy, but with an ADC, This is the Sunmo trial that Dr. Kamdar mentioned, a phase 3 randomized trial, also in transplant-ineligible second-line and beyond patients, 2-to-1 randomization to the combination of MOS and POLA. Mosunetuzumab is active in DLBCL, but has not been approved in that setting. It is approved in follicular lymphoma, but combined here with polatuzumab versus R-GemOx. And this is a fixed duration of therapy, as you see here, with the duration of therapy largely the same in both arms. And what we can see again here is a similar theme. Early separation of these progression-free survival curves, and that is sustained over time. And importantly, in this trial, published in JCO in October, we see an even lower CRS rate, about 35%. This is predominantly grade 1, and probably reflects a slightly different T-cell activation from mosunetuzumab. So this is very much an outpatient regimen, delivered outpatient in the clinical trial as well.
So, Gilles, we've already seen a couple of positive phase 3 trials combining glofitamab and another one with polatuzumab with GemOx. Just looking at those, and there are probably others out there, but just looking at those two, clinically, how do you choose between the two?
Well, I think it's a question of what do you want to achieve, where is the patient, and what can they tolerate. I think glofitamab is a little bit more tricky to manipulate. I mean, the CRS rate is higher. You have probably to eventually hospitalize the patient, and this is not practical in your practice. So, at least for the 1 or 2 first administration. However, there are patients in good shape, young. You can probably avoid that. You can release them with instructions, and if you work closely with a place where they can reach out in the middle of the night if they have fever, it's feasible. But it's more complicated. However, my feeling is that it's a more efficient drug in DLBCL than mosunetuzumab. But mosunetuzumab is very easy. I mean, as Krish mentioned, it's really mosunetuzumab POLA. You can give it outpatient and a few steroids to cover the risk of CRS, and that's it. So it depends on the patient. My conclusion of that is DLBCL, I don't use bispecific alone. I always try to find the partner, whether it's POLA, whether it's GemOx, whether eventually another one. I try to combine bispecific because you raise the CR rate by about 15 to 20%. So probably you have a better chance to benefit to your patients.
You don't use bispecific in diffuse large B-cell alone. Interesting. Manali? Is that used?
Only in third line. I use it by itself, but if now that this is on the NCCN guidelines, we have the option to choose a bispec with an ADC, MOS and POLA, or bispec with chemotherapy based on the STARGLOW study, which would be Glofit GemOx.
And what about POLA GemOx?
So our POLA GemOx, the POLARGO study, I kind of struggle to find its value today because majority of the times if I have treated my patients with the POLARIX regimen in frontline, if the patients have not stayed in remission for even 6 months, a re-challenge with the same regimen gets real hard. I find a place for our POLA GemOx truly when a bispec is not available, POLA has not been seen in frontline, and I use it a lot as bridging treatment post-apheresis.
Interesting. Okay, Krish.
So epcoritamab, another approved agent in DLBCL, as a monotherapy in third line and beyond, has also been studied in the second line setting. Here slightly differently as monotherapy in second line transplant ineligible patients versus either bendamustine rituximab or R-GemOx. Now, this study has not presented full data set, but we have seen by press release that the study is positive. So intriguing to see monotherapy. This is the only study I'm aware of that has monotherapy bispecific in that second line setting. And you can see the hazard ratio here, 0.74. But the majority of these patients actually did receive more than 2 prior lines of therapy. So we'll see what these data look like in contrast to the combination data we showed previously. Importantly, when we think about all these bispecific antibodies, as Gilles pointed out, there are some distinctions. There are differences in the step-up dosing. There are differences in when we see the CRS peak. And so those are summarized here. Largely with epcoritamab, we see not much CRS in the first 2 step-up doses, but predominantly with that first full dose. So the timing is important of when we're monitoring for CRS, still mostly grade 1. With glofitamab, we see this as typically with the first step-up dose, and then subsequently a much lower incidence of CRS with subsequent doses. And then in the STARGLOW and SUNMO trials, largely these follow the same pattern that we see for the bispecific component, but again, in SUNMO with mosunetuzumab, a much lower rate of CRS overall. So I think when you're implementing these in practice, it's really important to recognize when the CRS is most likely to occur, and it is different for each therapy. Most, if not all of these drugs now are given with dexamethasone as a pre-infusion med, but additionally can consider dexamethasone either in what we call pill in the pocket, or is extended for 1 to 2 days after the bispecific is given. So these are certainly being administered in the outpatient setting. If we think about bispecifics in the front line, what do we think is going to happen there? We've already seen some phase 1b, phase 2 studies. I'll just summarize those briefly. Epcoritamab with R-CHOP, you see here, 100% overall response rate, CR rate of nearly 90%, and the follow-up from this study has been very impressive in patients with high-risk large B-cell lymphoma. We've also seen similarly for glofitamab, combination both with R-CHOP and polatuzumab R-CHP from the Coalition study. This is an Australian study, and you see here 98% CR rate in high-risk patients. We have now fully enrolled the frontline study of glofitamab Pola R-CHP versus Pola R-CHP. It will take us some time to see the mature data from that trial, but ultimately we do expect bispecifics to make their way potentially to the frontline in DLBCL. What about patients who have had bispecifics? One of the things that has been emerging from our experience here is we recognize that one mechanism of resistance is a loss of CD20 expression or emergence of things like splice variants where perhaps CD20-directed therapies will no longer be as effective. And this rate remains to be defined, but has been as high as 60% in some case series that have been reported. We also know that there are other factors, tumor microenvironment, T-cell exhaustion, so we will need other therapies beyond bispecifics as well. So in that sense, one opportunity is to think about a T-cell engager with a different target, CD19, and that is the focus of surovatamig. So surovatamig is a T-cell engaging bispecific antibody from AstraZeneca that is being studied, has been studied already extensively in a late phase setting, so in a late line setting, third line and beyond DLBCL as well as follicular lymphoma. These data were updated at ASH, summarized here. And like we see for CD20 T-cell engagers, the ability to induce deep responses, CR rates of around 45% at the higher doses seen, intriguingly a CRS profile that also looks to be mostly grade 1 and potentially compatible in some settings with outpatient therapy. This is just to show you that there is a dose-response effect, so it has taken some time to find the right dose of surovatamig, but it looks like that dose is at least 15 milligrams or higher. And one of the things that I think is a little bit different about surovatamig being CD19 being the target, we do see some ICANS here, potentially a little bit more than we are used to seeing with CD20 T-cell engagers. There is some consideration for CD19 expression in the blood-brain barrier, albeit it is very low grade, mostly grade 1, some grade 2, but very short-lived. So this agent is being also combined in upfront studies. The first of these is the Soundtrack D2 study looking at our mini-CHOP for older adults, and you can see older defined here as age greater than 80 or somebody between the ages of 65 and 79 who might be unfit for full-dose R-CHOP, and you see 3 arms here. Our mini-CHOP and surovatamig, our mini-CHOP as the control arm, and the study starts with a safety run-in of the combination of our mini-CHOP and surovatamig. So we expect data probably 2027 and beyond.
So quick question to Gilles. I know we're not supposed to do indirect comparison, but let's just say you had a randomized trial between surovatamig and one of the CD20 bispecifics out there. What do you think you would see in comparative efficacy and tolerability?
I think it's a little bit hard to answer that because, as you said, the impression is that surovatamig has a major efficacy. Is that superior? We don't treat the same patients. There was a step-up learning curve with the first patient we treated with the first bispecific. So variability came when we knew how to select patient, we knew what kind of patient we'll treat and things like that. So I'm a little bit cautious, but my impression still is that it's probably a higher response rate, a higher CR rate. We don't have many data on durability so far. We don't have data regarding the possible loss of expression of CD19, which could be a concern for CAR-T later. So there are many questions open, but it's clearly a very attractive drug.
And what do you think you'd see in terms of toxicity? More ICANS?
I think there was in the development a few more ICANS. I think now they stabilize the questions very, very low, a little bit like 1 or 2%.
And Manali, getting back to just using the available bispecifics that we have, first of all, I'm kind of curious how you think it would go giving R-CHOP and a bispecific at the same time in terms of chemo side effects and side effects from the bispecifics. Also, any thoughts about preemptive tocilizumab? You guys don't seem to do it, but the myeloma people do it.
So I'll answer the latter question because we don't have data with preemptive tocilizumab. We don't do it in our institution. I don't know if Dr. Salles or Dr. Patel do.
I know you all do it.
Yeah. And then with regards to chemotherapy plus bispec with frontline clinical studies, actually it's the same idea of debulking. The minute you debulk the tumor, it's actually very easy to keep going with the bispec. Each one of us have had bispec plus chemo as frontline trials at our institutions, and the patients are doing phenomenally well. We really have to just make sure that we monitor them for infections.
Tafelen.
So I'm going to go through the last part quickly. So we have another CD19 targeting therapy, a monoclonal antibody, tafasitamab, really engineered to enhance with an immune modulator, in this case lenalidomide, first approved in the L-MIND trial. We have a long-term follow-up from this trial. And what we see is this is a different population of patients, probably more selected, but for those patients who achieve a CR, that can be very, very durable, as you can see here in the top blue line. And so we have seen now a press release also for the frontline trial, as was alluded to earlier, a very large global phase 3 trial comparing tafelen R-CHOP to a control arm of R-CHOP, and we hope to see these data very soon at ASCO. So just in summary, I think we have multiple areas where we can use bispecifics, increasingly in the second line for patients who may not be able to access CAR T cells, and can be safely combined with chemo or ADCs. And then these agents can also be used in post-CAR relapse, and frontline trials are coming. And so again, these are our takeaways. We have multiple opportunities to use bispecifics and use these safely in community settings. So I think this is going to be a very important advance.
So, Krish, any predictions about how we're going to be treating people in terms of upfront TAFA after ASCO? Do you think we're going to be doing it?
Yeah, I think the key question for me, Neil, is the benefit extended to all subgroups? If that is the case, then I think, at least for what we've seen for the hazard ratio, that is in the ballpark of what we saw in Polarix. So it is a very, let's say if the GCB patients benefit in that trial, then I think that is going to be a new relevant standard of care.
And what about the ABC patients?
I think there you have to think about combining 2 drugs, right, versus 1. So I think lenalidomide can have its challenges. We see more cytopenias. So I'm particularly interested in the GCB subgroup.
So we're going to move on now, talk about CAR T and diffuse large B cell, and Manali is going to go through some of the data.
These are my disclosures. So everyone in the room is quite aware that prior to CAR T-cell therapy, the prognosis of relapse refractory chemotherapy-resistant large B-cell lymphoma was dismal. Median was less than 6 months. And then, with the advent of these 3 pivotal clinical trials investigating axi-cell in ZUMA-1, Tisa-cell in Juliet, and Lyso-cell in Transcend, this led to FDA approval and a huge sea change in the outcomes of patients with relapse refractory large B-cell lymphoma. Because these are not head-to-head trials, there is obviously cross-comparison, but the idea to really bring this to your fore is to highlight the age. The median age on the Transcend study was 63, but the ranges was 18 to 86. So age is not an automatic exclusion for CAR T-cell therapy. With regards to overall response rates, it was in the range of 70%, complete response rate 50%. It's important based on the co-stim domain how the expansion happens. With axi-cell, it's a CD28 co-stim domain. As a result, we see higher grade CRS and ICANS here in the range of 11%, 32%. With regards to 4-1BB products like Tisacel and Lysocell, we have grade 3 CRS in the range of 2% and grade 3 neurotoxicity in the range of 10%. The biggest question is, can we cure relapse refractory large B-cell lymphoma patients? And the answer is yes. In the third line setting, we have now the 5-year overall survival across the 3 pivotal studies, giving us a cure of 38 to 40%. 40% of patients who would have otherwise succumbed to their disease are now cured by CAR T-cell therapy. So anything that works in third line, we want to test it in the highest risk subset in second line. And this was basically a subset that's high risk second line large B-cell lymphoma that are either primary refractory or relapse within 1 year of having received chemoimmunotherapy. This set off a slew of 3 randomized clinical trials, ZUMA-7, Transform, and Belinda, each comparing the CAR T construct against head-to-head in fit patients with autotransplant. Everybody knows this, but ZUMA-7 and Transform were positive studies. CAR T-cell therapy led to a significantly superior event-free survival compared to autotransplant, and it displaced the 3.5-decade standard of autotransplant and made CAR T the new norm. Belinda was a negative study. There were key differences between ZUMA-7 and Transform. Only steroids were allowed for bridging in ZUMA-7, and no crossover was permitted. On Transform, 1 cycle of salvage chemo was allowed, and crossover was permitted. With regards to complete response rate, it was high in terms of 65%, 74% versus only 30% on the autotransplant arm. And again, you can see the trend with grade 3 or higher CRS, 6% on ZUMA-7 versus 1% on Transform, grade 3 or higher neurotoxicity, 21% on ZUMA-7 and 4% on Transform. We now have individual follow-up of all of these studies extending out to 4 years, where we can now start talking about, can we cure these patients? And the answer is yes. On the ZUMA-7 study at the 4-year mark, the 4-year overall survival was 55%. 55% who could be salvaged to a cure with CAR T-cell therapy. In this population, it is much lower if you take these patients to an autotransplant. With regards to Lysocell, we have a 3-year follow-up and a 4-year follow-up. The 3-year follow-up as well as the 4-year follow-up tell the same story. This is especially important despite a crossover. 62% of patients who went to the autotransplant arm crossed over to Lysocell after they failed or did not respond to chemo. Here, the 4-year overall survival is 52% on the Lysocell arm. I think the big question that I get a lot from my community partners is, how does it matter if I give you CAR T in the third line setting or in the second line setting? And I think the Transform study highlights this very well. People who got Lysocell in second line, the 2-year overall survival was 95%. On the other hand, people who crossed over and then got Lysocell, so first auto, then Lysocell, the 2-year overall survival dipped to 78%. So third line, we can cure CAR T in about 38 to 40% of patients. Second line, you can now cure CAR T in about 55% of patients. Patient-reported outcomes is a very important variable that's beginning to emerge in a lot of clinical studies. Across the 2 studies, they did show clinically meaningful improvement in quality of life for patients randomized to CAR T-cell therapy. And at this point in time, Lysocell and axi-cell are now approved for fit patients with high-risk second-line diffuse large B-cell lymphoma. The big question then is, what about transplant-ineligible patients? What about unfit patients? Could they still be CAR eligible? And the answer is, I think yes. And this is multiple real-world studies actually showing that you can do CARs in these patients. I also have to vehemently point out that transplant eligibility is not the same as CAR T eligibility. Patients who are transplant ineligible are not necessarily CAR T ineligible. The best thing that they can get is a referral to the academic treating center or the community treating center that do look at figuring out how to optimize their ability to get to CAR T-cell therapy. We have all been part of this paper where we are really talking about who is eligible for CAR T-cell therapy. I usually give a tip to my community partners is that if you can think you can give R-GemOx, at least consider getting your patients to CAR T-cell therapy. So Pilot basically showed us that unfit patients can be successfully taken to Lysocell. This is a phase 2 single-arm study. Now has a median follow-up of 24 months, and you can see that the median overall survival has not been reached. Overall response rate was 80%, CR rate was 50%, and the patients were frail. The median overall survival has not been reached. It's very important to note that in this study, the grade 4 or grade 5 CRS was 0%, grade 4 or grade 5 ICANS was also 0%. The logistics. Obviously, the logistics are a big bane, not just for our community partners, but also for the CAR T treating side. We have to apheresis, then we have to manufacture. Manufacturing takes anywhere from 3 to 3.5 weeks. During that time, the cancer is not waiting, so you have to do bridging therapy. Bridging therapy, I typically like steroids or I like radiation to a bulky site. And a lot of these second-line regimens that have been approved, I typically use them in second-line, in bridging therapy, and then there is the infusion. I think I will this is the end of this section, but I will start by saying we no longer have to keep our patients for 4 weeks at the CAR T treating site. It has now gone down to 2 weeks. So it is something that patients, their care partners, all can finagle.
So just to pick up on a couple of things, I'm going to ask the next question, all three of you, which is starting with you, Gilles, the oldest patient you've had receive CAR T. And also, in addition to that, can you comment on choice of CAR T?
So the second question is easier, and maybe we are biased in some places of the Northeast, or at least in our place. I think the vast majority of our patients receive Lysocell today. It's easy. We do that in the ambulatory setting. How about half or a little bit more, maybe 60% of the patients come because they have a CRS grade 1, because we still hospitalize CRS grade 1 for 3-4 days in the hospital. But, most of that is done in the ambulatory practice, even in New York City. So Lysocell for the vast majority of patients. I reserve Axicell for really somebody young, fit, with a rapidly expansive tumors that we were unable to control because the immediate response is probably faster by a few days. I didn't got exactly your first question.
The oldest patient is going to CAR T.
Oh, the oldest. I think I have treated somebody who is 86, and in the center is 92, and I have treated people with even mild cognitive impairment, and it went very well. So I have a video. I will have to send it to you.
Great, awesome. I love videos. So, Krish, your oldest patient is going for CAR T. And also, again, your thoughts about, do you agree with Lysocell in general, and what situation do you use Axicell?
Yeah, the oldest patient I've treated personally is 91, and I would agree with Dr. Salles that 4-1BB CARs generally are much friendlier in terms of toxicity profile. So that was actually an investigational CAR T-cell that was a 4-1BB CAR.
We actually presented at the San Antonio Breast Cancer meeting a 103-year-old woman who was living by herself, taking care of herself, wanted to be treated, and was treated successfully. But anyhow, your oldest patient, and also, Manali, I want you to comment a little bit about what happens in a CAR T center, what happens in a cellular therapy center. We're working with you and many other people to develop a program to actually have community-based general oncologists visit a CAR T center, because I feel like we don't really have a good feel for what really the patients are going through, what's happening there. Your oldest patient, and also can you talk a little bit about what happens, what would a general oncologist see if they came in and made rounds with you?
Yeah. My oldest patient is 89, still doing quite well. With regards to what really happens, I will steal Matt Lunning's line, which is brain to vein. I think before we even put on the machine, the time is passing, because the tumor cadence is quite proliferative. So I usually tell my community partners, if you think someone's relapsing, just pick up the phone and call your treating site, because that's where the clock actually does matter. Once we see the patients, we basically evaluate them on multiple levels, make sure that they have a caregiver, make sure they have all the understanding of CAR T-cell therapy, and then after that, we basically ask for insurance authorization. That part is the biggest roadblock. And sometimes it could take 4 days, sometimes it could take a whole 10 days. It matters because we really don't want to treat our patients prior to apheresis with cytotoxic therapy as much as possible. Then they get on the machine. On the apheresis, it's a 1-day commitment to the treating center, after which they're basically waiting for their cells to get manufactured. During this time, it's very essential to figure out what's the cadence of the tumor burden. If it is something that can be managed, I typically have my community partner reach out to their rad oncologist and basically give radiation to the bulky site. However, in diffuse large B-cell lymphoma, it's usually a systemic thing. Sometimes I see if steroids can just cut it, it's most likely a gestalt, and if not, I use some of the second-line regimens. Post-apheresis, I'm much more comfortable in getting my patients bridging treatment. I've also started using a lot of bispecific antibodies, and if my community partners cannot do that at their site, I typically onboard my patient, and it's really a matter of getting to lymphodepletion chemo. Also, it's very important to note that patients who are in stable disease, partial response, progressive disease, or a complete response, all of these 4 patients are eligible for CAR. So if someone has achieved a complete response with bridging therapy, they will still get CAR. There are 9 patients on the Transform study who actually got Lysocell in a CR. So it's a myth that patients have to either achieve a stable control or some response to get to CAR. That is actually not true. Once they get to CAR T-cell therapy, they finished LD chemo, we determine if this can be given in an outpatient setting, if it's logistically feasible, performance status feasible, and we monitor them for 14 days. At the 14th day mark, we have our APPs evaluate them, our advanced nurse practitioners and physician assistants to evaluate if they are fit to go back to their primary oncologist. I think it's very essential here that our partnership be strengthened because it's very critical that between day 15 and day 30, they still will have cytopenias. They're a very high risk of infection, and it's important that this partnership just strengthens. Usually by day 30, the cytopenias have resolved, patients usually feel better, and then they are anyway back in their home feeling better. And then I will say that for the first 6 months, we keep them on prophylaxis. I'll talk about that in a little bit. And majority of the times, we're always available. So any doubt, any question, something doesn't look right, it's just so essential that the partnership be maintained.
So the video producer in me was like, oh, that was a perfect short video. I would love to distribute what you just said. We're going to get more into this topic of the interface between tertiary centers and the community, bispecifics, CAR T in general, as we go on tonight. But that was really a great introduction to it. We'll talk more about that. Zoom at 12.
Yep, so second line works. We can cure patients. Why not get them to 100% cure? So I think with that in mind, we're bringing CARs to the frontline setting. And this is Zoom at 12. Now it has a much longer follow-up, but ideally these are high-risk large B-cell lymphoma patients with an IPI of 3 or over or double-hit lymphoma who, after 2 cycles of chemoimmunotherapy, have achieved a Deauville score of 4 or 5. So we know that if on an interim scan, they still have cancer, that is a very high-risk set, and usually more chemo doesn't work. This is obviously prior to MRD, so this is a little more antiquated study, but nonetheless, these patients went on to Axi-cell. A total of 40 patients participated in this study. 78% had an IPI of 3 or over. And you can see the Kaplan-Meier curve just keeps shifting up. The overall response rate, 89%, CR rate, 78%, with a 3-year PFS of 75%. So we went from 40% to 55%, now to 75%. Obviously, it's Axi-cell. Most common side effects were cytopenias. Besides that, grade 3 or higher CRS, 8%. Grade 3 or higher neurotoxicity was 23%. So now we're talking about some other platforms, and I will say that wrapped Captigene autoleucel It's a CD19-directed CAR T-cell therapy that utilizes something called the T-charge platform that preserves the T-cell stemness, plus it's only a 2-day manufacturing time, followed by release testing. The phase 2 study looked quite good with the primary endpoint of complete response, median follow-up of 16 months. The CR rate was 62%. Median prior lines of treatment were 2. Despite the 2-day manufacturing, about 60% of patients received bridging therapy. That was because of the release testing. It took that much more time. The safety was manageable. Grade 3 or higher CRS 6%, grade 3 or higher ICANS 5%. 2 doses of lymphodepletion chemo were tested, and eventually the risk-benefit profile supported the lower dose. They are going head forward in frontline high-risk large B-cell lymphoma, exactly the same schema as the ZUMA-12 study that I showed. Most common was cytopenias. No grade 3 or higher CRS events were seen here. 2% grade 3 or higher ICANS. However, the biggest difference with this product is the time to onset of CRS. It's a little delayed. It's 11 days, and then for ICANS was 15 days. Response rate was great, CR rate of 74% at a median follow-up of 8.5 months. Median PFS is not reached, but it's a shorter follow-up. I think I am very pumped about the next slew of clinical trials that have all started and are enrolling as we speak. This is the next wave of trials. This is a bi-CAR, either bispecific or bicistronic, CD19 and CD20 dual target CARs. 3 constructs have been developed by 3 companies. Each of them in their phase 1-2 effort have shown a CR rate of 74% with a median PFS that's not reached. ICANS was seen in some, CRS was seen in some, but eventually optimization has occurred. And phase 3 randomized clinical trials are currently open, comparing investigator choice versus CD19, CD20 bicars. So I think it has the potential to displace the existing standard of care. Now pivoting to CAR T-cell therapy toxicities, I will say for my community partners, I'm just going to breeze through this, but giving them really some tricks to figure out what to really look for. I think when you get the patient back, it's very important to understand that CARs can have on-target, off-target toxicities. One of the on-target off-tumor toxicity is B-cell depletion. As a result, patients are hypogammaglobulinemic. So we check their IgG, and if it's less than 400, it does not matter if the patient feels stellar. The idea is to give them IVIG to protect them from having infection. Risk of infection is high, and therefore it's very important to look at it. Usually this is managed at the CAR-T treating site because of the time to onset. CRS is the first week, ICANS is the second week. Usually if CRS happens, ICANS may follow. And corticosteroids is the rule to manage both of these toxicities. Tocilizumab is used for CRS. There are times patients can have refractory CRS and ICANS, and this is when we pull in anakinra, which is an IL-1 antagonist. Sometimes we pull in siltuximab, and sometimes we pull in ruxolitinib. There is a new term called cartopenia. These cytopenias are either because of heavily pretreated patients, lymphodepleting chemotherapy, infections, secondary marrow neoplasm, very rarely MDS because these patients are older. So they have a new terminology called ICAT, which is immune effector cell-associated hematotoxicity. The general patterns, like we talked about, usually the first 30 days are early toxicities, and these cytopenias are almost always common and essentially will resolve quickly. Short term is when people will still have cytopenias between day 30 and 90, and prolonged are the ones that we all, as CAR-T treating doctors, do not want to see, because these are the patients, thankfully only 10%, usually ballpark, but these are the patients that do struggle with needing infusions and GCSF shots. And CAR hematotox score is really evolving as a variable. It divides patients into low risk, intermediate risk, high risk to basically inform the patient and the community partner what a high risk looks like. A high risk CAR hematotox score would mean that the cytopenias are going to take much longer to resolve. We talked about hypogammaglobulinemia. We talked about infection prophylaxis. Here is usually PCP prophylaxis is mandated for the first 6 months at least. HSV prophylaxis for the first 6 months to 1 year. Infections are the main driver of non-relapse mortality after CAR T-cell therapy. And you can see across the three products, the non-relapse mortality for CAR T-cell therapy ranges from 4% to 7%. Very rare toxicities could be an HLH-like syndrome. And of course, there was concern about secondary malignancies, especially T-cell lymphoma. But if you look at the big picture, we're going for a cure. And essentially, this risk is quite minimal. So this was a paper that we all worked with. This is looking at CIBMTR registry for patients who receive Lysocell and all the clinical trials that actually utilize Lysocell. This was a subset of 1,500 patients. And the net is that CRS or ICANS after infusion is extremely rare beyond 2 weeks of infusion. So if it happens in the first 14 days. Only 3% of patients had CRS or ICANS as a delayed issue. So based on that, we had some regulatory updates that happened in 2025, because of which the REMS requirement has been fully removed. Previously, patients had to stay at the treating site for 30 days. That has been reduced to 14 days. And most importantly, patients couldn't drive previously for 8 weeks. Now it's gone down to 2 weeks. So it's a win-win for a lot of not just the patients, but also their caregivers, and also the ability for patients to get back home with their primary oncologist. I do believe that expanding access to community centers is absolutely important. We can do this in various ways. Education is key. Operationalizing and simplification of this process is essential. But I do believe the path forward really is based on how do we do this in the system rather than the center. It's also essential to understand who receives CAR, not just who can deliver it.
Awesome. So a couple quick questions to you, Gilles, before we move on. First-line CAR T, do you see that happening in the near future, and what type of situation? Also, can you maybe elaborate a little bit more on what we've learned about second cancer? I love the cartiopenia. I like it. A lot of stuff there, though. So the other question is update on second cancers, particularly these insertion T-cell lymphomas. What's up with that, and what's up with first-line therapy?
So first-line therapy, I think, will be an exception. Given the trials that are coming up and the results that we expect, I will say, as you said, these were patients having an insufficient response at 2 cycles. Maybe 2 cycles is a little bit early at 4 cycles, and those were the patients eligible in second line. So I think, given the challenges, the logistics and things like that, personally, I don't see them routinely coming into first line, but you have patients that are progressing through therapy. They respond at 2 cycles of R-CHOP, and they progress after that. You have to do something very rapidly, and CAR-T is really on the plan. Second cancer, I think the data are out now. It's a little bit more frequent with myeloma, and with the product used in myeloma. I think the numbers with lymphoma is 1 in 5,000 or less, so it's really anecdotal for something that cure patients, and now we have follow-up for many years. We have many registries. Yes, there is a risk. It's not theoretical. It's real. But 1 in 5,000. I think there is a higher risk of MDS and other myeloid disorders, especially when patients are referred late. And I will emphasize what Manali has said. If you think this patient had failed his first-line therapy, think about CAR-T immediately, sooner rather than later.
So, Krish, do you bring up second cancers as a possibility to your patients? And what do you think the mechanism is of exactly what's happening?
Yeah, it's something I think we all talk about because it is a risk. It's also one of the things that is required for long-term surveillance for patients. But it is such a low risk, so that's usually what I inform the patient of. I think it's a really interesting question about mechanism. We think that some of that may be due to insertion site mutagenesis, so where the CAR receptor itself goes in the T cell may disrupt other genes and lead to oncogenic changes. It's probably not a one-hit occurrence because we see it at such a low incidence. It probably takes multitudes of hits, and so at least some of the data that Gilles was referring to in myeloma and in lymphoma suggests that when you really analyze some of these CAR-T-associated T-cell lymphomas, many of these patients had baseline germline abnormalities that predispose them to potential mutagenesis. So I think it's a very, very low risk for most patients.
All right, well, we're going to continue on, and now I'll talk about CAR-T and follicular lymphoma. And again, Gilles, I was kind of surprised because initially it didn't seem like there was that much excitement, and then I started looking at the data going, wow, this works.
Yeah, it works and it's exciting. So the same disclosures will pass. Well, I like to start with this slide because I think this is the first patient I treated probably 7 or 8 years ago. I wasn't in the US at that time in a clinical trial. And this patient, as you can see, was 53-year-old. He had received R-CHOP, he had received RDX, obinutuzumab, lenalidomide, bendamustine plus obinutuzumab, and he came to us with this pattern of disease. 3 months later, he's still alive. So there are patients that benefited from this disease, and there was a biopsy. It was not transformed. It was follicular lymphoma. So this patient was in this trial, actually, ZUMA-5. This was the first trial, axi-cell in relapse and refractory indolent lymphoma, both follicular and marginal zone. And I think that was a great result that was published now 4 years ago in Lancet Oncology. You get to 80% overall response rate in this refractory patient. This is something we never saw before. I mean, we were in the 30-40% with the drug we had. So 80%, including a majority, 79% of CR for those. And quite an interesting progression-free survival curve. And you can see, you may say, oh, but this survival curve, this is not cure, it's trickled down with time. Well, look into detail of what was updated recently by Satwa Nilapu and colleagues. You have here on the left the duration of response, which means patients who achieved a response and stay in response. Look at how many patients were at 36 months, 3 years. There were about 60 patients. There are still about 50 patients at risk at 5 years, 2 relapses, which means that the rate of relapse is less than 5%. If you look in another way, the cumulative risk of relapse, again, you see these 2 tick on the upper curve. The lower curve are other factors leading to death. Unfortunately, we discussed that, infections, secondary neoplasia. These were very heavily treated patients at this time. And this explains the fact that the PFS curve is trickling down. But in terms of rate of relapse is very low, and it raises the question whether CAR-T may cure patients with follicular lymphoma or not. Well, that was the first product. Tisa-cell was tested in another study called ELARA. The results have been presented in different platforms. The CR rate may be a little bit lower, but different patients. They had to have a bone marrow to confirm complete response, so maybe you cannot compare. Overall, 70% or so complete response rate. And even in hard-to-treat patients, you are in the 60% rate. The updated result at 5 years was presented by Receptor at ASH. And again, exactly the same message. If you look after 36 months, they didn't show any relapse in this patient. So there is a signal here that, again, there are 45 or 40 patients that are followed after that. So you may start to think that potentially it's a cure for patients. There were some MRD assays performed in this trial, and as you can see, there were a number of patients that became MRD negative, maybe with more sensitive assay. This is something we should discuss probably today. We'll have some interesting way to predict the outcome of this patient. Finally, we talk a lot about Lysocell. The study is called Transcend again, and maybe a little bit different. There is a large cohort here on the right, which are patients in the third line or plus setting, but there is also a small cohort which were patients who were treated in second line, either because they had this early relapse within 24 months after initiating therapy, those called POD24, or they had several other adverse characteristics. So some were double refractory and things like that. Then what happens? You have now 95% or 94% of CR, both in second line and third line, overall response rate a little bit higher. So very, very impressive rate of complete response for this patient receiving Lysocell. Again, the data are only at 3 years at this time. They were updated during meetings. Similar trend, it's a little bit early to say. And again, maybe some population more difficult to treat still don't have the greatest benefit, but for the other ones, you have a major benefit, and it's still benefit for those who had received several lines of therapy and more difficult to treat. I think the same message that we just heard about DLBCL. 60% of the patient had a CRS, which means 40% of the patient didn't have a CRS. 84% didn't have ICANS. And when CRS occurs, it was essentially a grade 1. The other toxicity were rather classical. And again, these are patients we treat in the ambulatory setting. The long-term safety, there are a few cytopenia, but it diminishes with time. It's 5-10%, as we just heard. There is infection, but as you can see, it's less than 5-10% of infection on the long term. So it's really common in oncology patients that have been treated to see that. There is B-cell aplasia, and I think this is a real concern because a substantial number of our patients will have to receive supplemented IgIV for prolonged period. I follow patients that were treated 6-7 years ago that still receive IgIV, that still have detectable CAR-T, and they have no B cells. But they are alive with their disease, without disease. Sorry.
So one question, and maybe I'll ask Krish, and this really is a question for the entire evening that we're kind of going to get into, which is what comes first, CAR-T or bispecific? How are you thinking about that?
Yeah, right now in follicular lymphoma, both are available in the third-line setting. And I think the longer follow-up data for CAR-T really does beg the question, like, are we curing some of these patients? So I do think that it is becoming a harder and harder question to answer. I think in most circumstances, if patients can get to a CAR-T center and they understand the risks, they have the support, based on the long-term follow-up, I'm starting to favor CAR-T cell therapy in follicular lymphoma. But I think there are a lot of caveats there. There are challenges in terms of accessibility, and for those patients, bispecifics are really an extraordinary option.
Manali, I like your thoughts on this. And also, I love the patient-reported outcomes. Sometimes it's more or less informative to read in a trial, but I think it's often helpful to ask people who've actually seen patients to give their thoughts in terms of kind of what life is like for somebody who gets CAR-T versus a bispecific. CAR-T, theoretically, you have the one and done, but then you just went through all these things that may happen afterwards. Bispecifics, you're having more, maybe longer therapy, but again, not without risk. How do you compare the experience of the two?
Yeah, I think it is, first of all, it's patient dependent. A lot of patients say, I'm so much more willing to commit to one and done and then get the chance of a remission. And if that durability is what I really want, then CAR-T, it is for that patient. With bispecs, I think the patients just sometimes do not want CAR, don't have a caregiver, and then they cannot be getting CARs. I think it's also important in relapse refractory follicular lymphoma with regards to sequencing, it's true of DLBCL too, that we need to check for CD20. If the CD20 is negative, bispecs actually will not work in the relapse setting. And more heavily you treat your patients with follicular lymphoma, they're likely to actually become less expression on CD20. So it's so essential to do that tumor biopsy before you determine sequencing. I will have to talk about just the patient-reported outcomes. Dr. Ajay Major at the University of Colorado actually presented this data at ASH across a 15-center multi-institution study. It was looking at time toxicity. Time toxicity is a variable that we're also looking at, and it's interesting to see that in that retrospective study, CAR-T actually provided a higher PFS compared to bispecs. The time toxicity was slightly higher in the first 1 month, but then it picked up for bispecs for a much longer period of time. So I think we need novel variables to be able to also tell our patients what's best for them.
That's a great point. All right, Gilles, let's keep going.
Yeah, so, cross-trial comparisons are always hazardous, but I would just like to point two major things. The first one is the toxicity. We heard the fantastic result of Axicell, but unfortunately it's also the most toxic of this product. And as you can see, the rate of CRS with tisagenlecleucel, Tisacel, or Lysocel is lower, and the rate of ICANS is negligible. So very few grade 3, very well manageable. Regarding the CR rate and duration, we are in the 70 to 90%. We have, as you can see, 2/3 or 3/4 of the patients that are alive without relapse. Which one is the best? I don't know, but I will apply the same thing that I have done for DLBCL when choosing a product for my patients. Eligibility is a little bit different, and I adopted the schema which I drew for DLBCL because Many patients don't need bridging or need bridging with something light, a little bit of steroids, some antibody, something like that. The disease space, the disease burden, the risk of infection, that's different from what happens in DLBCL. But there is still the question of referral, there is still the question of caregivers, comorbidities, organ functions, and the choice of the product, and all the logistics that goes behind. 3 years ago, we drew this scheme and we are constantly adapting it. And right now it's the third line setting. I will assume that the question will be, are we using bispecific, which start to be approved in the second line? We'll hear about that very soon in combination, or are we choosing CAR-T? If bispecific have been used before, I think for sure CAR-T is really on the plate now and should be considered, especially for patients who relapse early. I put the other options for this patient who have really an option to control rapidly the disease. The other option, less intensive, are zanubrutinib, inotuzumab, rituximab, or eventually R-square if they haven't received it. So I think here, if they have received bispecific, CAR-T is really something below. And I have tried to put this graph, bispecifics are off the shelf, they are outpatients, it's an easy schedule in follicular, they have minimal constraints, they have also CRS during the first cycle. There is infection, and this can be lingering infection for a couple of months that lasts at least 6 months. Single agent is probably have a lower efficacy, and we don't have long-term data that we have with CAR-T, very high CR rate, one and done, and I believe that for follicular lymphoma this is true. A prolonged duration of CR, possibility of cure. Logistic is still here, hospitalization, proximity. I'm more concerned about the long-term IG supplementation because we don't have that with bispecific, and I put that in context for the patient in which I discussed CAR-T before bispecific. 2 studies that we need to watch. ZUMA-22, patient with relapsed refractory follicular lymphoma having failed at least 1 line of therapy and having relapsed within 24 months, or having received 2 prior lines of therapy. Randomization between axi-cel or between standard of care, which could be rituximab CHOP, rituximab bendamustine, or eventually rituximab lenalidomide, so-called R-square. Classical eligibility criteria, I don't have to go over that. I think the trial is still accruing, if I understand well. The other trial is called LIDA, and it's T-Gen-Leclerc versus standard of care. Again, some similar eligibility criteria, and the design is very similar. It's a T-cell versus standard of care. The trial is accruing in different places, if I understood well. So maybe, in a few years, we'll have early data, but also long-term data. Maybe the pitfall of those is that there is no bispecific in the control arm in neither of the studies. So the comparisons are a little bit old in terms of what we do. Manali already touched upon that. There are new CARs coming, and these are dual or bi-CAR. They target both CD19, CD20. Of course, if the patient have low CD20, that's not a question. But there are different designs, different toxicity. There are few patients treated with follicular lymphoma. I don't think we can, at this point, say which one is the best or one is the best. I think we'll have to wait and see how these drugs develop more rapidly in the DLBCL field. But this is probably another tool that will come for our patient with follicular lymphoma also.
So, Krish, optimal choice of CAR-T in FL.
Yeah, I think the important thing in FL that's distinct is that long-term view. So I think safety is really imperative, and I typically would reach for a 4-1BB CAR. Like we talked about earlier, that risk of CRS and ICANS is much lower with those. In follicular, we have 2, either T-cell or lysocell. I personally prefer lysocell in that setting.
So, Manali, a question from the audience about prophylactic antibiotics and use of vaccinations, patients with the CAR-T and bispecifics.
Yeah, very important. I think for the first 30 days, after day 15, we typically are fine with giving them GCSF support for neutropenia, which is quite common. Usually neutropenia, as long as they are neutropenic, we typically give them antibiotics like the fluoxetins, fluoroquinolones, and we also make sure they are on an antifungal. Usually by day 30, day 25, the neutropenia is resolving. So as long as neutropenia anemia resolves, you can stop those, and then they continue PJP prophylaxis and HSV prophylaxis. We typically continue PJP prophylaxis for 6 months, HSV prophylaxis for 6 months to up to a year, depending on which CAR-T treating site the patient is being sent to. Vaccinations is certainly something that we must talk about because there is no consensus. There was an expert opinion paper, and I do believe that some centers actually vaccinate patients like childhood vaccinations, like a transplant protocol at the 1-year mark. I will say we don't do that. We typically go back to age-related surveillance vaccinations after 3 months of having received CAR T-cell therapy.
So, Gilles, you mentioned zanubrutinib, obinutuzumab. In what situations, if any, are you using it, and what's your experience with it?
Well, right now, many of our patients will have received bispecifics before. A few patients will have lost CD20. But it's an approach that is useful for patients. And obinutuzumab is not that difficult to manipulate if you take some precaution with the first infusion. Zanubrutinib is an easy drug. I haven't treated many patients with this regimen, but I consider it for the patients that have went through several lines of therapy, have received probably the 2 other agents and relapsed, but it's a minority of patients those days, and I think the benefit of the other agents are so superior that it comes later on.
All right, Krish, let's talk about some other therapies for FL.
All right. So we talked a little bit about lenalidomide earlier, and I'll just kind of highlight and remind us why this drug is important in follicular lymphoma, or why immunomodulatory drugs are. There are probably a multitude of different mechanisms of action, but in particular, we know that lenalidomide enhances T-cell number and activity and K-cell number and activity. That was shown by John Gribben many years ago. And so it pairs well with antibody-based therapies in follicular lymphoma. And as you know, we recently saw the 5-year overall survival data from the Augment trial, which is R-squared in the second-line setting, and it's really outstanding, 83% at 5 years. So what do we do with that backbone in mind? This is kind of where we are in 26. This is my own approach, but it very similarly matches, I think, guideline-based therapy. And I'm going to talk about some of the trials that inform this. But in particular, when we think about pure follicular lymphoma relapse, we're not talking about transformed disease as well. In the second line, we now have 2 new regimens to think about. Both are based on the backbone of R-squared. First came Tafa R-squared, we'll talk about that, and then more recently epcoritamab R-squared. And then in the third line, as was highlighted earlier, we have monotherapy bispecifics, CAR T-cells, and some other approaches that we'll talk about as well. So I'm going to talk first about the triplet combination of tafasitamab, the CD19 monoclonal antibody, with R-squared. This is from the INMIND phase 3 randomized trial. We saw this at ASH of 2024. And this was also a placebo-controlled trial, so placebo R-squared. And you see here, these are second-line and beyond patients with follicular lymphoma. There were marginal zone patients also enrolled, but the data here that we'll show are for follicular lymphoma patients. And you see the stratification factors here. This study was meant to enrich for high-risk patients as well. And I'm going to point out that while we think about Augment, it is important to remember that Augment was a slightly different patient population. That study's control arm was rituximab monotherapy. So that inherently influences the composition and the characteristic of patients that enrolled. In contrast, INMIND was actually quite enriched for high-risk patients. And you see this here, where if we look at bulk disease by Guelph criteria definition, more than 80% of the patients in this trial had bulk disease. And if we look at things like FLIPI 3 through 5, that's 50%. If we look at POD24, it was almost 50%, or around 40%, in this trial. So that colors how we look at the efficacy, and in particular when we think about the control arm. So you can see first and foremost that the primary endpoint of the study, progression-free survival, a clear separation of the curves, the triplet combination on top, and R-squared in the green curve. If we look at overall survival, the follow-up is immature, so hard to determine if there will be an overall survival benefit or not yet. But the PFS benefit is distinct, as you can see that here. When we look across different subgroups, those high-risk categories that Gilles mentioned, POD24, early relapse within 24 months of initial therapy, those patients who have had anti-CD20 antibodies and are refractory to a CD20-containing regimen, we see consistent effect in favor of the triplet combination of TAFA R squared in all of these subgroups. Of course, the outcomes are slightly different for each of these. I think in follicular lymphoma, an important concept, not a regulatory endpoint, but for clinicians, is time to next therapy, right? So we know that our patients can have radiographic relapse of follicular lymphoma, but they may not need to start their next anti-lymphoma therapy right away. So what we're capturing here is when would we actually start the next therapy after they enrolled in the trial? And you can see here also a really marked difference in the two arms. And remember, this was a placebo-controlled trial. And importantly, many of our patients in this study are doing quite well. Nearly 80% or more in the triplet combination had not initiated a later line of therapy after the study assigned therapy, compared to a median time to next treatment of just around a little bit more than 2 years in the R squared arm. In terms of adverse events, there's a lot here, but I'm just going to summarize and see this. This is quite remarkable. It's very rare in oncology that we add a third drug and we see virtually no toxicity. I will say there's slight differences, very minuscule in terms of risk of cytopenias and infection, but certainly not substantially so. And that, I think, is one of the greatest strengths of that regimen, is that adding the tafasitamab really did not add any toxicity. So if you are routinely giving R squared, I think at least you can think about giving tafasitamab. Now, time toxicity is important. The tafasitamab is given weekly for about a 12-week period of time, but then it does decrease with time. I'm just going to... Go ahead.
I'm sorry. I was going to ask Gilles. First, we were talking about cell mods and diffuse large B-cell, golcadomide. What about cell mods in FL? And what's your current use of TAFA R squared?
So I think I continue to say that I love R square. I don't like lenalidomide that much. So, it's a drug we have to manipulate. I think adding TAFA on that is really appealing because you don't have the question of CRS. We don't use it a lot again, but it's a recent approval, and we have the option of bispecifics. But when you don't want to deal with the bispecific issues, it's a great combination. Again, you mentioned it's almost equal. There is a little bit infection still carry on during this trial, and they may carry on for quite some time. And for the patient, it's quite demanding. Every week for 3 months, 3 cycles, 3 months actually, and then every 2 weeks thereafter until 1 year. So, it's a demanding treatment for follicular lymphoma. The benefit is about 1 year delay. I don't see really the curve plateauing. So, it's a useful regimen. Is that the preferable partner for R square? I'm not sure.
What? Cell mods. What about the myeloma cell mods? Would you rather see iberdomide R squared or?
No, I think the golcadomide has given really fantastic response rate. I think it was like in the 80-90%. So again, there is some hematological toxicity here, but we'll find a way to probably develop golcadomide in this setting and find the right combination, the right partnership. Probably we'll keep lenalidomide for years because we know perfectly well to manipulate this drug. You decrease a little bit the dose. You decrease the duration of treatment between 2 cycles eventually. We manipulate that quite easily, I will say. But we'll learn how to manipulate golcadomide, and I hope it will come as another tool in the field.
Manali, another question from the audience. Your current approach at POD24?
If I have a trial, I'll get them on a clinical trial. I've seen excellent responses with the CD19 CAR for POD24, but then I'm going to show you the triplet with EPCOR plus R square, enriched for POD24 patients, and they actually did quite well. So if CAR is not available, then I would go for a bispec plus R square combination.
All righty, let's continue.
So Dr. Kamdar is foreshadowing. I'm going to leave much of this for her because I don't want to steal her thunder. But just briefly to that point, we do have an approval for a triplet combination of a bispecific in the backbone of R squared, epcoritamab specifically. You see this study design here, fixed duration regimen compared to R squared, a step-up dosing consistent. I'm actually just going to use this to contrast to the InMind study. So this study also was enriched for higher risk patients, similar proportion of FLIPI-3/5. Bulk disease was defined differently in this trial, so hard to make a direct comparison. And again, caveats being there are probably different populations, different patients in both trials, but this study also enriched for patients with high-risk disease, POD24, and those who are refractory to an anti-CD20 antibody. These are the top-line data. Dr. Kamdar is going to go over these in more detail, but you can see very impressive difference in terms of progression-free survival. The follow-up for this trial is shorter. And then if we look across subgroups just to show that consistent favoring of the triplet regimen, including in high-risk patients. I'll leave these for Dr. Kamdar to review later. I'll just briefly touch on, again, in contrast to tafasitamab, we do have to think about CRS when using epcoritamab in this backbone, but fortunately that risk of CRS is very low, 26% as observed in the study, and you see where the incidence of that was. That is mostly just a fever alone and very predictable. So I do think that this is a very manageable CRS risk profile in this setting. However, we do see a lot more infections as we add a more effective B-cell depleting drug, and that was also seen in this trial where infection rate was higher in the triplet combination compared to R-squared, as was neutropenia, so something to note. This is also probably something Dr. Kamdar will highlight, but I will show there are other combinations of immunomodulatory drugs with bispecifics also being studied. I will kind of shift gears to the non-bispecifics that are available in the third-line setting and beyond. So we mentioned zanubrutinib, a BTK inhibitor. This is an interesting trial because largely we have not seen much single-agent activity of BTK inhibitors in follicular lymphoma. So I think perhaps many of us were somewhat surprised by this trial. This is a phase 2 randomized study. Different population. This is zanubrutinib and obinutuzumab compared to obinutuzumab monotherapy. So think again about a patient who might be a good candidate for antibody alone. This might perhaps include older, frailer patients or those in whom triplet combinations may not be desirable. This study's primary endpoint was overall response rate. And even though this study is a different patient population, you can see there are still high-risk patients in this study as well. So here's the progression-free survival curve. The median PFS is 22.1 months compared to 10.3 months with obinutuzumab alone. So a very reasonable regimen to think about in third-line and beyond patients who might not be able to get a bispecific. Perhaps maybe sometimes patients have a hard time tolerating lenalidomide. That can be a challenge as well. And the toxicity is largely consistent with zanubrutinib monotherapy. Shifting gears to things we saw in DLBCL, I think this is a really exciting trial. This started as an investigator-initiated study done by Juan Aldericchio at the University of Miami. Loncastuximab tesirine, the CD19 ADC we were talking about in DLBCL, in combination with rituximab in patients second line and beyond. And you see here Lonca given just like we give it in DLBCL, higher dose for the first 2 cycles, and then you see the rituximab dosing here. Now, one of the interesting things about this study design was this adaptive response. So essentially patients get assessed for response at varied time points, and depending on their response determines their ongoing therapy, which is shown in the right. So if you get to week 21 and you're in a CR, then rituximab essentially maintenance, or really 2 doses in 16 weeks. If you had a partial response, you continue the Lonca and the rituximab further. So this is not an approved regimen, but based on the data that have been presented now, you see here a very high overall response rate, 97%, a CR rate at week 12, a very early response assessment time point of 67%, and a PFS of 94.6%. So this has made its way into the NCCN guidelines for third line and beyond. This just shows the durability of those responses, so we can see early CRs and they can be durable, and you can see a few patients converting to deeper responses with time as well. These are the traditional Kaplan-Meier curves, very impressive in terms of adverse events, consistent with what we would expect for the component therapies, no new safety signals. And then, Neil, you asked about immunomodulatory drugs, golcadomide, CELMoD, in follicular lymphoma, just briefly summarizing data here that was presented at ASH from a phase 2 cohort. looking in follicular lymphoma specifically, golcadomide given for 14 days on, 14 days off with rituximab. And you see at the 0.4 milligram dose a nearly 80% CR rate, which is much higher than we expect with lenalidomide in a similar population. And then adverse events, largely manageable, neutropenia that essentially resolves with drug holder management of GCSF. And so this combination is being studied in an actively enrolling phase 3 trial called GOLSEEK-4, combining Golca and rituximab compared to either Len-R or chemoimmunotherapy in the second-line setting. And this is the study design here. So these are our key takeaways. We've now got 2 triplet regimens with a backbone of R squared in the second line and beyond from phase 3 trials, and in our third line setting, a myriad of treatment options here. A lot more to come. We didn't talk so much about surovatamig. There is also another CD19 bispecific, MK1045, also being studied in follicular lymphoma, and BCL6 degraders, so a lot to come.
So, Gilles, has Golcad been looked at in myeloma?
I pass. I don't know.
Not that I'm aware of, no.
And well, you go back to you, Gilles, again. I was interested in this idea of response-adapted strategy that was just mentioned with the LANCA-T. Do you see more of that in the future? It almost reminds me of some time-limited strategy, like even prostate cancer, we do intermittent therapy, maybe incorporating MRD. What do you think about that strategy moving forward?
Yeah, I think it's an interesting strategy, and maybe we'll have to refine the way we treat patients in the near future. Right now, we do that a little bit empirically. You know, you treat a patient with a combo of bispecific plus GEMOX, and the patient achieves a CR after 2 cycles. And maybe you do 2 other cycles of GEMOX and you stop, or you drop one of the drug. You do a combination with lenalidomide. The patient is often neutropenic, and you drop the lenalidomide or you diminish the dose and you stop. I think what will happen, and I don't know what the regulatory status of the approval of the cell-free DNA in Florida, but in oncology you are using different companies, but one of them has been pioneering or pivoting to the field of lymphoma, Natera, and I think these tests are available for lymphoma. So we don't know how to use them right now, but we will be learning that, and I think we will probably go for more and more in follicular and possibly in DLBCL to duration of treatment based on the quality of response.
It's interesting you mentioned cell-free DNA, because I always think about MRD when I think about hematologic cancers, and yet, as you say, we're going to be talking about cell-free DNA all weekend here with solid tumors. But you're saying Natera has sort of a tumor-informed assay?
Yeah. Yeah, I mean, there were already a ctDNA with a test that was developed based on the work of Asha Lizadeh in Stanford, and it was called the little company called Foresight. It was being bought by Natera, and they are really expanding the hematology field with cell-free DNA assay. Right now, closer to the ones they are using in solid tumor, but probably they will have mixed approach depending on the tumor. And it's already available for order.
Really interesting.
In our jurisdiction, at least.
All right, Manali, bispecifics.
So Dr. Patel has made some of my presentation already easy, so I'm going to go over the byline here, is that relapsed refractory follicular lymphoma remains an unmet need. You can see on the left that lymphoma-related deaths are still 10% at 10 years. Overall survival goes down by each line of treatment. And then obviously Dr. Salles talked about POD24, which is a high-risk subset. Here the 5-year overall survival is only 50%. So the treatment goals for relapsed follicular lymphoma are really about not just having efficacious or high CR rates, but also making sure that they're durable, making sure they're time limited, hopefully a potential cure, and most importantly have manageable short and long-term toxicities with an improvement in quality of life. So with regards to CD20 bispecific T-cell engagers, we have 2 approved products here, mosunetuzumab, epcoritamab. Mosunetuzumab is IV as well as sub-Q. It's given time limited. Epcoritamab is available sub-Q. It's given until progression or toxicity. Now we have follow-up of both of these pivotal studies. With mosunetuzumab, we have a 5-year follow-up. GO29781 was a phase 2 single-arm study, enrolled 90 patients in the third-line follicular lymphoma setting. At a median follow-up of 60 months, you can see the progression-free survival, 5-year PFS of 36%. The CR rate for this study was 60%, and a common theme that emerges in bispecific T-cell engagers is serious infections because they are given for a longer period of time. Serious infections, as reported by investigators, is 20%. However, median time to next treatment, 64 months. It was also similar median PFS in POD24 versus non-POD24. Then we have epcoritamab at a median follow-up of now 3 years. In the expansion cohort, you see this phase 1-2 study that enrolled 149 patients. It was actually done in the peak of the pandemic. The CR rate, again very similar, 65%. Grade 3 or higher serious infections, 35%. Because it was done in the peak of the COVID pandemic, they had to distribute in terms of probability of PFS by width adjustment for COVID-19. So without COVID-19 adjustment, the median PFS was 15 months. With adjustment, it was 34 months. As we talked about, the 3-year overall survival, 80%, serious infections, 35%, median time to next treatment, 45 months. So Dr. Patel already talked about this amazing clinical trial spearheaded by Lorenzo Falci. This study basically has now gotten us 2 approvals in second line. I'm going to go towards just the meat of this and figure out how do we do this in clinical practice. So we have the EPCOR FL1 study that essentially demonstrated EPCOR plus Ritux plus lenalidomide for 1 year versus R-square for 1 year. EPCOR, Ritux, lenalidomide was statistically significant and superior with regards to the dual primary endpoints, which was overall response rate and PFS. I think the eligibility criteria needs to be looked into. So for the InMind study, which was a triplet, the eligibility criteria was patients who relapse after 1 prior line of treatment. They did not have to get chemotherapy. So they could have just received monotherapy with Ritux, and they could have been enrolled on the InMind study. On the EPCOR FL1 study, here patients had to receive chemoimmunotherapy frontline. Then only were they allowed to get randomized. However, the label is different. The label is relapse. So now we have to figure out when do we use a triplet with the InMind and when do we use the EPCOR study. Despite that, I will say that the results of this study are quite stellar. 100% of patients had chemoimmunotherapy. 44% of patients were enriched for POD24. 37% of patients were double refractory. So refractory to rituximab, refractory to chemoimmunotherapy. It's been a while I have seen this kind of a PFS with a hazard ratio of 0.2 translating into a 79% risk reduction. Overall response rate in the 90s, complete response rate 83% with the triplet. In terms of moving forward with safety, the overall survival, currently it is not reached in the triplet arm in both of these arms, but we will see what this data looks like. Looks like there is a positive trend to the triplet, but longer follow-up awaits. With regards to safety, grade 3 or higher infections were seen in 33% of patients. CRS, as Dr. Patel mentioned, it was actually quite manageable and low grade. Going on forward, head-to-head, like EPCOR plus R-square, we also have now the phase 3 Celestimo study, which compares R-square to Mosun plus lenalidomide. This is a doublet because Mosun cannot be combined with rituximab but binds to the same epitope as rituximab. So Mosun plus len. We needed to enroll North American patients, so this is just a single-arm phase 2 extension cohort of the US patients. And you can see that the baseline characteristics were different. Double refractory, you can see, was 17% of patients, 30% of patients had POD24. The median follow-up now is 12.7 months, complete response rate 87%. So looking quite good even here. Most common adverse events were fatigue, a maculopapular rash, and constipation. So
before you go on, just I don't know about you, but my brain's about going full, so to speak. But Could you just talk a little bit about, you just went through InMind, Mosin, Len, and EBCO R squared. And there's probably more, but let's just talk about those three in terms of how you see them fitting in clinically. What comes first, or when you?
Yeah, I think right now Mosin-Len is not approved because the Celestimo study is yet to read out. But say, for example, it also gets approved in second line. So now we have a doublet, Mosin-Len, then we have a triplet, InMind, and we have EBCO R square. I think the bottom line is safety. I would probably go with safety and see what the grade 3 or higher infection risk looks like in the bispecific trials. I would also go with eligibility. For example, someone got rituximab 4 years ago and now has relapsed. What are the options for this patient? Is R square out of the box? I think the Augment study does say that R square is better than R, but InMind or EBCO R square, I'm not quite certain if R square in that setting is also better than the triplet for somebody who has been rituximab sensitive and achieved a duration of response for 4 or long years. However, in the double refractory setting or the rituximab refractory setting, I do believe that these triplets would add value, or even the Mosin-Len would add value. In the POD24 setting, I think these would make immense benefit. At the end of the day, I think durability matters. I'm so keen to figure out what EBCO FL looks like in terms of durability at the 5-year mark. Also, with regards to safety, I think a grade 3 or higher infection risk of 33% is notable. So for these patients, we must check their IgGs. We must make sure that they are on PJP prophylaxis, HSV prophylaxis, and it's ongoing for 1 whole year. So it's really first safety and then figure out how long did they actually achieve a remission from their previous treatments.
So, Krish, would you like to give a second opinion in terms of what Manali I was just kind of flashing. I wonder what ChatGPT or Open Evidence would say if I asked them that question. But you want to take another shot at clinically, like maybe making it a little simpler?
Yeah, I think a lot of what Manali said I would agree with. Ultimately, which regimen has the best durable response with the least late toxicity, which is going to be infection. The other thing I would add that is, I think, maybe an opportunity we'll see for the Mosin combination is that time toxicity. Mosunetuzumab is given on a 3-week interval, whereas the other 2 triplet-based regimens we shared are given weekly for a while. And so I have found, say if you look in the third-line setting where we have EBCO and Mosin, my patients do prefer to come to the clinic less often, and so if they are able to do that with the mosunetuzumab-based regimen, that might win the day.
So our motto for the weekend is all day. Tomorrow, Sunday, all day, just like this. So hang on. Here we go.
So because these agents have actually shown such high efficacy in the second line and beyond setting, I think it's just time that we start testing them in the frontline setting. So with that in mind, we have Morning Sun that was presented by Dr. John Burke, wherein a fixed duration subcute mosunetuzumab with maintenance therapy was given in previously untreated high tumor burden follicular lymphoma patients. So this study enrolled patients who met Guelph criteria for high tumor burden. They were treatment-naive follicular lymphoma patients. They received 17 cycles of subcu Mosin, followed by maintenance every 8 weeks for up to 1 year. It was optional. In terms of characteristics, you can see this does represent a treatment frontline high tumor burden patient population. The net is that the complete response rate was 65%, overall response rate 88%. In terms of progression-free survival, at the 18-month follow-up, the PFS was 85%. With regards to duration of response, 18-month event-free survival was 87%. 67% were actually eligible for maintenance, 45% received maintenance. No CRS occurred during maintenance. So these frontline studies in high tumor burden FL tell us that there may be value in extending these constructs and hopefully making it a completely chemo-free world for our patients with treatment-naive high tumor burden follicular lymphoma. Odronextamab is not yet approved in the United States, but Olympia 1 and 2 studies are basically randomized studies testing Odro versus investigator choice. It could be our chemo in various fashion. I'm very pumped about EPCOR FL2 as well as the Morning Light study. These are basically EPCOR or Mosun head-to-head with our chemo followed by maintenance of both of these agents. So I do believe that these are not single agent. By the way, EPCO is combined with R-square, Mosun is combined with Len. So it's a triplet versus chemoimmunotherapy, doublet versus chemoimmunotherapy. I think this may have a potential to change our standard of care. So the big question is, what for our low tumor burden patients? I think essentially we do a lot of watch and wait for these patients, but in patients who are either anxious or don't like the idea of low tumor burden watch and wait, we give them single agent rituximab. Also, the big question is, if we add a better construct, is there a possibility of cure? So with that in mind, SWOG, so the NCI group, this is an intergroup study, S2308, that has been designed in low tumor burden follicular lymphoma. Patients can receive radiation before. This is going to be a cohort of almost 600 patients that will be randomized 1:1 to getting Ritux sub-Q weekly for 4, followed by every 2 months for 4. Versus mosunetuzumab sub-Q every 21 days for a total of 8 cycles. This is open at a lot of intergroup sites, so please look out for this clinical trial for your patients. Surovatamig, this is a fully human CD19, CD3 bispecific T-cell engager. We saw some data with diffuse large B-cell lymphoma. This is data in relapsed refractory follicular lymphoma. This is the 3-year follow-up study of the first in human phase 1 study investigating Suro in patients who have had 2 or more prior lines of treatment. Suro has to be given in a stepwise fashion, and it was administered for a total of up to 2 years. It was a heavily pretreated cohort, and I will say that the follicular lymphoma results are really stellar. The POD24 population was 36%, nearly 44% had 3 to 4 lines of treatment, 15% of patients had more than 5 lines of treatment. 11% had seen CD19 CARs before, 8% had seen CD20 bispecific T-cell engagers before, and here at a median follow-up of 16 months in such a heavily pretreated population, and by the way, the ages went from 33 to 86, so it was age agnostic, overall response rate was 100% with a complete response rate of 93%. I think I'm very eager to see the follow-up. This is actually a 3-year follow-up, so at the 3-year mark, you can see that the 18-month estimate is almost 81% duration of response. Also important to highlight that could this be something that could be used in sequencing? So a lot of our patients are now double exposed, which would mean having seen CAR T-cell therapy and CD20 bispecific T-cell engagers, there were 8 patients with dual exposed, and these patients have achieved a CR, remain in a CR. All 11 patients who completed 2 years of Suro remain in CR of treatment. Safety obviously matters, heavily pretreated cohort, mindful of the fact that infections is a risk. You can see that here. Thankfully, CRS, ICANS were all low grade with the step-up dosing and all resolved. So moving forward, Suro is also going head-to-head in the phase 3 Soundtrack F1 study, and the idea is to basically do a safety run-in of Suro plus rituximab, and for 7 cycles, either followed by observation or followed by maintenance Suro or followed by chemoimmunotherapy followed by rituximab maintenance. So I think the world's going to change probably in the next 3 to 4 years if all of these studies actually pan out to be positive, given that they're going head-to-head with chemoimmunotherapy. So I think good news for our patients.
Absolutely. Just a couple of follow-up questions. So, Gilles, would you like to predict what might be seen in the, first of all, the SWOG study of mosunetuzumab against R with low volume disease, and then the Suro study, Suro plus R versus R, not just efficacy, but also tolerability and quality of life?
So I think the rituximab versus mosunetuzumab will raise questions regarding, as we said, the infection rate and a couple of issues like that, including the loss of CD20. However, I would say mosunetuzumab single agent is a well-tolerated regimen, and I use it a lot until we got the approval of the triplets. This was my favorite regimen in the third-line setting when patients will not go to CAR, and sometimes have approved for patients in second-line setting. So mosunetuzumab is an easy-to-manage drug. I believe that the response rate will be higher, the PFS will be higher. The question in patients with this low tumor burden is what's a reasonable endpoint? Is that the time to progression with 2 centimeters lymph node on the scan, as mentioned? Is that the time to next treatment, which is very subjective? Is it overall survival? We need another 15 years. So I think there will be, it's a very important trial. It's meaningful. How are we going to interpret it in the future will be complicated. I think the trial with bispecific in the first line are important. And I think whether it's the Mosun-Len, EPCOR-R² or Suro, I have a tendency to think that they have the potential to be equal or superior to chemotherapy, like actually R² was. We just published the result of 10 years of relevance, R² versus R-CHOP or BR.
Right.
The curve are identical at 10 years. So, R² is manageable. However, these were long treatment. And I think with bispecific, we are going to shorter term treatment, like 6 months, one of the arm of the Suro. And maybe we have to rethink maintenance, Yep. Maybe with bispecific, we can give every 3 months or every 4 months or, something like that. So I think the field will change. I think in the future, very few patients will receive R-CHOP, despite the recent results. Very few will receive BR also. And I think we are going to manipulate these drugs in patients with follicular lymphoma and find the best way to sequence. But as just said, the field is completely open with many new questions.
So thanks so much to the faculty. We'll be back here tomorrow morning, 8 a.m., talking about CLL. Have a great night. Thank you so much. Great job.
Thank you.